I love the twin focus that you bring to both a study of organizations and a study of the people who exist within them and shape them. And there's so much for us to learn about how organizations work by hearing about the individual work experiences of different folks. Because the fact is that different folks we experience those work settings in like really radically different ways. And these are largely structured by social phenomena and our social identities. They play a huge role in patterning us. So I was wondering I have a few questions. I was wondering if you could talk a little bit about some of the differences that you did notice between, in terms of the categories of workers, right? So that occupational hierarchy, which is sort of a feature of the status system, lots of organizations do have these very clear hierarchies. Sometimes they're actually more subtle. And if you could talk a little bit about how that played out differently for the doctors and the nurses and the tech workers.
Yeah, absolutely. So one of the things that I learned pretty early on in this project was that healthcare as a field is extremely hierarchical and very, very stratified. Doctors inhibit a very clear space at the top of the industry, at the top of the hierarchy, rather, of the workers that I spoke with, and that was pretty much unquestioned. They were very clear that they were at the top of the pyramid, and they liked it that way, and that was something that they were pretty happy about. Nurses were in the middle, technicians were at the bottom relative to the other workers. And interestingly, what I learned is that that had a lot of impact on how Black workers in all three of those fields saw the types of challenges that they encountered in the workplace and how they tried to address those challenges. So for Black doctors, because of the status that being a doctor offers in medicine and in the healthcare field, one of the things that I learned was that while they experienced racial issues and pressures in interpersonal interactions in some cases, by and large, that was not for them a primary source of frustration in their jobs. And I have some thoughts about why that was the case, and I can talk about that more later if people are interested. But I found that for doctors, they were more likely to categorize it as what I refer to in the book as a that one time experience. In other words, there was that one time when somebody said this thing to me that was inappropriate, or this patient was weird, or something like this happened. But they were very clear that those were usually rare, isolated incidents. Now, this isn't to say that race had no impact on doctors and how they experienced their work lives, but more so to say that when they talked about the ways that they felt that race had an impact on them as Black workers, it was much more so in terms of structural and cultural issues. The lack of access to mentors, the exclusion from social networks, cultural presumptions that as Black workers, they would have to work a little bit harder because they wouldn't receive the benefit of the doubt. Those sorts of issues were much more likely, or much more commonly reported as from Black doctors, as ways that they perceive racial challenges in the workplace. Nurses gave me very different responses. Nurses were more likely to say that while they also observed some structural challenges, they were way more likely to see very frequent, consistent, overtly racial experiences in their work. And there are a number of examples of this in the book that I cite. But they weren't, and I think it's important to think about hierarchy again, because nurses, unlike doctors, weren't quite at that position where their status put them in a role where they could either exempt themselves from interactions with patients or draw on the heightened status of being a doctor to shield themselves to some degree from some of the interpersonal challenges that doctors faced. And technicians were in a position where, relative to doctors and nurses, they were at the lower end of the hierarchy. And what that meant for many Black technicians was that this position meant that they often had to deal with, as I mentioned just in the introduction, they often had to deal with nurses who were predominantly white in ways that could sometimes prove conflictual and challenging. Nurses, sometimes within their purview, sometimes outside of their purview, would engage in delegating tasks or creating assignments for technicians. Black technicians often found that very frustrating, especially when those tasks were outside of the bounds of what they were actually supposed to be doing by virtue of their job descriptions. So they also, like nurses, were a lot more likely to identify interpersonal challenges that they faced in the workforce, but they also were very likely to highlight that as a consequence of institutional arrangements and how institutional structures that lead to overwork and that push workers, particularly nurses, to do a lot more, to work longer hours without support, left nurses in a very tenuous position where they were often frustrated. And in many cases, technicians felt they had to bear the brunt of that frustration because of the position that they held in the structure. Oh, are you muted?
I'm
Okay.
muted. Yeah, thank you for that. So, and did you find, so this is sort of an organizational question. Um, uh, did you find that there were some organizational differences? So, for example, state-run hospitals versus private hospitals, Catholic hospitals. Was there a difference there?
So that's a great question. In one of the chapters in the book, I actually devote an entire chapter to focusing on Black workers in public healthcare systems. Mm-hmm. So workers who are in the public sector, who are in hospitals that are publicly funded, which are a declining number of our hospitals today, again, because of the massive disinvestment that the public sector has seen. And what I found there was really interesting. It really highlighted that although there are differences in how Black doctors, nurses, and technicians perceive their work by virtue of their position in the occupational structure, the disinvestment in the public sphere has also created some common ground for those healthcare workers. And by and large, many of those workers were really attuned to the fact that they were experiencing what I refer to in the book as a concept that I call racial outsourcing, and a related concept that I call equity work. So I argue in the book that when organizations say that they want to focus more on racial diversity and be more available to communities of color, but they do not put the resources, the energy, the programming, the funding, the attention into doing so, what often happens is they leave that work up to Black professionals and their employ. And that is the process that I refer to as racial outsourcing. Organizations say that they want this done, they do not do it, but they do either tacitly or explicitly take advantage of the labor of Black professionals in their employ to do that work of making the organizational space more available to communities of color. And I found that in public sector facilities, many Black healthcare workers were acutely aware of the fact that racial outsourcing was happening, and that they were doing what I call the equity work, the labor of having to do that additional work of making these organizations more available, making sure that communities of color are treated more fairly, more equitably, more humanely, as the case may be. And in the public sector, because the populations that these hospitals serve are frequently low-income communities, they are disproportionately people of color, the racial outsourcing and the amount and character and nature of equity work that these employees did became very stark and very vivid as they found themselves very frequently offsetting their white colleagues' stereotypes about the patients that they had to serve, of working much longer and much longer and without the resources that they needed to make sure that the populations that they were serving got the care and attention that they needed, going out of their way to try to create environments that offset the overarching history and contemporary nature of healthcare and medicine, where Black populations are often mistreated and stereotyped and not believed about their pain. This ultimately became pretty much a second job. It put these healthcare workers in a position where the virtue of this equity work that they did was an enormous amount of labor that they were carrying by virtue of institutional arrangements that they often could not control, or felt that they could not control, but that still benefited healthcare facilities because it allowed them to perpetuate themselves as being places that were attuned to these issues of diversity and that were concerned with communities of color and the care that they received.
Wow. I would imagine that that could create a situation of much higher burnout for these workers. At the same time, I'm curious if that also helped to facilitate a kind of mobilizing on the part of these folks to work for better, at a collective level, work for better arrangements for how hospitals work with the communities where they're located. Was there was there signs of either of those, the burnout, and then also signs of potential collective organizing?
Right. Well, certainly burnout came up anecdotally through a lot of the interviews that I did. And to some degree, that is unfortunately a facet of the medical profession right now. Doctors show, and data on this was the case before we entered a global pandemic, but even before the coronavirus hit, doctors showed very, very high rates of burnout and frustration from the work that they are doing. And again, I think a lot of this goes back to institutional arrangements and the ways in which we have structured the way that we work. We often do not do it in a way that's beneficial for or advantageous for most workers. And doctors certainly bear the brunt of that. And again, that was before a global pandemic happened and we started learning just about how doctors weren't having access to PPE and other things that they need in order to do their jobs well. So certainly for Black doctors, the experiences of racial outsourcing and the consequential equity work that results, I learned anecdotally from my interviews, definitely put them in a position where they were very likely to feel burned out, frustrated, exhausted. There's a memorable story that I recount in chapter 5 where a Black woman doctor described very poignantly feeling exploited by the institution where she worked and describing herself as feeling like a mammy figure because she just put so much into the organization and she felt they were very aware of the additional work that she was doing and we're all too happy to take advantage of that labor, again, without offering resources, compensation, support, or any of those things. So that's a long answer, but to a great question about how this does create a particular racialized form of burnout. To your second question about what that means for organizing, what I found was that because Black healthcare workers are still so underrepresented in these professions, they often are working to solve these problems in a rather piecemeal fashion. And what I mean by that is that they're able to see how these issues are present and they're able to see things that need to be done. But because they are usually underrepresented, because there's not often a sense that the organization wants to collectively address these issues, I did not find that in most cases they were kind of widely banding together at a large scale with other healthcare workers to try to resolve these issues. I found what I always talk about when I talk about this book is that ultimately what I find is a story of individuals who are trying to solve structural problems. And we know as social scientists and sociologists in particular, that does not work. A few individuals scattered here and there in an organization don't solve an organizational level problem. But I found that a lot of my respondents were simply trying to do just that, in part because of where they were positioned, in part because of what they saw as the constraints and limitations available to them by virtue of institutional arrangements. So what that meant, for example, for Black doctors, was that they would see structural issues as a problem for other aspiring Black doctors, the exclusion from networks, like I said, the lack of access to mentors and so forth. But they would respond to that by trying to be available themselves as mentors to pretty much any younger Black person who expressed an interest in medicine. On the one hand, fantastic. It is important to have more of those types of networks and relationships in the healthcare industry. And certainly we know that Black workers are under-resourced and under-networked when it comes to having access to mentors and networks that can aid in your occupational mobility. But then on the other hand, you've got this lone Black doctor who's already working an 80-hour week, and that's on a slow week, already working an 80-hour week, who then is taking on this additional job of being available to any person who approaches them who's interested in the profession. It's unsustainable. You just simply cannot have people who are in that position of being an individual trying to solve those problems, trying to solve a problem in that fashion. So again, a longer answer than maybe what you were looking for, but I did not see a number of examples of large scale collective efforts to try to solve these issues. But I think, again, that's largely due to the extent to which these workers are underrepresented and the extent to which institutional arrangements really put limitations on their ability to work in that fashion.